Good morning, Mohammed and Khalid. Do you hear us?
Good morning.
Yes.
We hear you well.
Assalamu alaikum.
Salam, Mohammed. So, do you want to present the case? And then we'll have a short discussion
I'll
after.
just introduce my team, please. Mohammed Barakat Riyami, myself, my colleague Dr. Khalid, and we have our scrub nurse Ahlam, and our supporting team, Salim Naqbali and Shabib. I will give the hand to Dr. Khalid to present the case.
Can we get the slides, please? So today we have 58-year-old male with vast medical history of diabetes and hypertension. He also had history of CAD, had PCI to LAD diagonal bifurcation at another institution in 2017. That was complicated by acute stent thrombosis, and that was treated with aspiration thrombectomy at the time. He is having limited mobility due to degenerative disc disease. Recently he was having CCS class 3 angina, and he was seen in the clinic and brought for angio. He was in good medical therapy. Since his infarction in 2017, his ejection fraction was about 35 to 40%. He has been in good medical therapy, including all the 4 pillars of heart failure treatment, plus at least 3 anti-anginal medications. And his ECG was unremarkable, no ischemic changes. Echocardiogram showed EF of 35 to 40%, which is stable as compared to prior echo. Regional motion abnormalities in the LAD territory due to his previous infarction. His labs were okay, mostly, except of course for uncontrolled diabetes and high LDL, but renal function and hemoglobin were okay. Do you hear me?
Yes, we do hear you.
Because I didn't know, the sound went a little bit like silent. Anyway, so this patient was initially advised for, we did angio that showed distal left main tight 70-80% stenosis. The LAD diagonal stents were patent with mild ISR and had 80% stenosis in the circ. RCA was dominant or codominant with mid about 50% lesion only. So initially he was offered surgery, but he was reluctant for open heart surgery and asked for PCI. We had a heart team discussion and we decided to offer him IVUS guided PCI to left main with regulating stent. So I think those are the pictures you are seeing. Can we go next? Okay, this is the spider view. So basically we were not sure about the bifurcation. We were not sure about the how much this osseous circ is involved. So we decided to proceed with imaging guidance. So we actually went right femoral 7 French sheath. We put vein sheath as well. And then we decided to get access in the left side. Only 5 French sheath we kept there in the left femoral artery, and this is basically just as a backup in case we need to go with LV support. So we were ready for LV support in case we needed that, but then we went to check LVEDB, and LVEDB was only 15. So patient is well optimized. We decided to proceed without upfront LV support. So we did the imaging, and maybe we can show you the run from the LAD and from the circ, and then we will let you know what we have done so far. Can we please show the IVUS images? No, let it run. This is the LAD, yeah? So from the beginning, go from the beginning, please.
Do you see the images?
Yeah, we do see.
Okay.
So this is the IVUS run from the LAD stent. And we see the stent is undersized proximally, and the vessel there is really calcified, calcific LAD. But then we come to the, this is proximal LAD. So a lot of calcium is almost 3/4, and in some area distally we're like 360-degree arc of calcium. So here we are still within the stent, and now we are out of the stent. We have 180-degree arc of calcium, and then of course we are going to the left main, and we'll see the circ coming here. See, that's the circ. It looks open, wide open here. Distal left main is very tight. We get an area of 3.5 here, and we have calcification only in the distal left main, but the mid shaft seems to be fine, and the ostium is okay. So this is the run from the LAD, and then we'll show you the run from the circ. So this is the circ. We are starting in the OM branch, just after the disease, and then this is going into the lesion. So here we have like almost 360-degree arc of calcium, and then basically the main issue here is to see the ostial circ, so which actually wasn't as bad as we thought. Actually we got an area of around more than 6 in the ostial circ. So this is why, accordingly, we will plan our strategy. So you want to discuss, or you want us to tell you what we have done so far?
Let's wait for a discussion with the panelists before we proceed. Any comment from the panelists? Given that the history of stent thrombosis, this patient, as you can see, the stent and the LAD is well opposed, and has a history of stent thrombosis, would have this changed your decision to go for surgery or PCI? Any?
Yeah, thank you. I think we would need to know a little more about the mechanism of stent thrombosis. Was it pharmacological, or was it simply because the stent was undersized? I have to say the stent looked a little bit small, but not massively so. I probably think that unless there was a problem with antiplatelet compliance, I think PCI here is still reasonable.
Yes. So I think that, you need to strongly revisit coronary bypass surgery in this patient, but understand that the patient was resistant. And that's particularly because of there's so many lesions here in the in-stent restenosis stent thrombosis, and concern that that might happen again.
Okay. Any comment?
Yeah. So, the question of a stent thrombosis becomes actually a big concern if the patient is not compliant, because you're going to commit a patient to a very complicated distal left main and probably bifurcation stenting, and with an ejection fraction of 35. So, and again, I echo his concern of going back and discussing surgery, because once you commit yourself and the patient is not trustworthy to commit to his medication, has become a big concern actually.
Yeah, I think CABG is probably here is the best option for the patient, given the complexity of the lesion, and patient has LV dysfunction, good target for bypass. I think if surgery is doable or a patient is candid, probably this will be my first option.
Okay, Khalid, so what will be your strategy in this case? 2 stents up front, or provisional stenting, left main LAD? But before that, would you do some sort of debulking because of the arc of calcium?
Yes, actually we have done debulking already. So I will just let you know what we have done so far. So we did rotational atherectomy from left main to LAD using 1.75 millimeter burr. And then we did rotational atherectomy of the circ using 1.25 millimeter bar because the OM is actually small vessel. So we did that, and actually the patient was very stable during the rotational atherectomy run. We didn't feel that we really need any support. But we have, of course, the access ready, just in case. Then after that, we decided to treat the circ with the cutting balloon. So we used 2.5 cutting balloon after the atherectomy. And then we actually treated the circ with DCB, 275 millimeter drug-coated balloon. And then we went to the left main LAD, and we opened that with 3.5 millimeter cutting balloon. And maybe we can show you the result after all of this, at least the angiogram. So can we please show the...
Just to add to Khalid, so actually we went, we did rotablator to the LAD, and we did also rotablator with 1.25 to the left circumflex. So we did rotational atherectomy for both vessels.
Okay.
Okay.
So this is after the run in the LAD. Shows the
Next.
circ. No, shows the circ. Yeah, shows the circ. Yeah. So this is 1.25 to the circ. Okay.
Next.
Next. Yeah. So this is after the rotational atherectomy. So you see the lesion has opened slightly, and then we did a cutting balloon at that point.
Did you use
Yes.
the
So this is a
rotor
cutting
drive?
balloon. 2.5/15. Okay. There was some dissection, so we and then we treated with the DEB. So this is DEB 275/25, almost for 70 seconds. During the inflation, patient was completely stable. There was no drop in blood pressure. Okay, so there's some dissection, but there's no flow limiting. So we decided that we will stop at this point for the circ. And then next. So this is a cutting balloon, 3.5/10 in the distal left main. Next. Okay. Next. So we'll take a picture now after the cutting balloon.
Mohammed, using cutting balloon with the wire and the side branch, may I ask the panelists, is there any concern? Or?
Yeah, my fellow asked me the same question just before I came. Is it safe to use a cutting balloon with another wire? I said I tend not to, but there are occasions where you probably have to if you want to maintain a side branch, and I suppose the theoretical risk of the cutting balloon cutting the wire is there, but seems unlikely to be a problem, so probably better to avoid, but you probably can do it.
Any comment?
Yeah. Well, I think I can use it if I'm ready to stent it.
Okay.
If I don't think it's a stentable vessel, it's not huge, so I don't.
Very good.
Generally.
Mohammed, may I ask you, are you using the rota drive wire or the ordinary rota wire?
So we used the rotafloppy. I think I don't know.
Rota flop, okay. But not the rota drive wire, which is new wire for the rotablation, which with a Sahi technology, which is a one torque technology. It's more because the rota wire is very flimsy, and this one gives you more flexibility in crossing the lesion, and use it up front instead of using wire and exchange it with over the wire balloon. Any comment? So. You'll use one stent strategy or two stent strategy?
So we are actually planning to go with the one stent strategy, and then we'll see if we have to do kissing, we'll do kissing if required.
12 and 18?
But now we will go with the NC balloon. This is 4O NC balloon. just to make sure that we open the vessel nicely. And as you can see, the blood pressure is okay.
Okay. Anybody will go with two-stent strategy? Any comments from the panelists?
No, I think the provisional stent strategy is a good one here. I guess, reference to the previous question, whether or not you would withdraw the wire before the cutting balloon.
Okay.
12 and 18.
No.
I have to say, I think provisional here is a good idea, but I'm surprised that the circumflex doesn't look worse on the IVUS, because angiographically it does look quite tight, the ostium. So I think before we got the IVUS, I assumed that we probably would need a two-stent strategy because of how tight the circumflex looked. But you believe the IVUS, and a provisional's not a bad idea, and you've got an option of a second stent if you need to. Would you do a culotte here to complete, or a tap if the circ needed stenting?
Yeah, I think T-tap would be a good way to go here. I think it can be very complicated with the previous stents in there to try and do culotte at this case.
Can I ask, Khalid, salam alaikum, this is Dr. Jassim from the panel. Have you done IVUS after this all rota and cutting balloon? Because as I see, there is a distal. There is a distal eccentric calcium punch, and just at the bifurcation of the left main LAD, which can make you some like stent. So would I suggest to do IVUS, and maybe you can go for IVL here? I think it's a good idea. Just to and then you go with the professional stenting. It will be very helpful.
We can do that for you. I think that's a good idea to go with the IVUS in the left main LAD. So can we go with IVUS?
I think that's an. Sorry.
If I may add something, and when you're dealing with the ostium of the circ, I'd be very concerned if it's angiographically looks severe and it's not severe on IVUS. One of the issues, especially with this angulation, with this calcium, is when as you pull it back, it might actually jump as it comes close to the ostium, and you miss actually the true assessment of the osteal circ. So, because it does look actually severe on angiography. So I'll be very concerned at that point.
Okay.
That's what I was going to say. I think
we had that issue of jumping from the run from the LAD, but the run from the circ was a smooth run.
Okay.
To avoid that, sometimes I will go to a manual pullback rather than an automated, just for the ostium, because you can then push the IVUS forward and gently back just to try and get a sense of what the ostium looks like.
Okay. So what are you doing now, Mohammed? IVUS?
We are doing a run from the LAD to left main.
Okay. Can you run a commentary, please? Khalid?
Okay, start.
Okay.
Naam.
Can you run a commentary on the IVUS, please?
We are not yet there, so we'll let you know once we have, because we are just having an issue with the rota now. This is the used rota. So
Who's the IVUS?
IVUS. I mean the IVUS, sorry.
Okay.
Can you see what's the problem? Can you see what's the problem?
No problem. Just go inside. Go inside.
Yeah, I am full. So I am full, but where is the? Okay, good.
Okay, start.
We are good. So let's start. So okay, this adjust the speed. How much?
Yeah.
Okay, let's go. So you see the IVUS now?
Okay.
So we were in the stent and now we actually jumped into the proximal LAD. So This is already the left main. Okay. Can we see the bifurcation here? Maybe I think we have to do another, this is the bifurcation. Maybe we have to do another run from the circ. How about that?
Okay.
We'll see
What
the
size?
ostial circ again.
Okay. What size of stent you will use?
So we are planning 3.5 22 stent from LAD to left main. And we'll post dilate to 5.0 in the left main. Because that's the size of the left main is 5.0. And proximal LAD is actually 4 to 4.5. But where we're starting within the stent is about 3.5 to 4.
Okay. So what stent you are using?
Dr. Khalid, what is the
What?
distance between all the stent to the ostial or the left main? You don't think you should go overlap?
We
with the
measured about
proximal
18 millimeter by ibis.
I don't know, but it looks fine because I think it can take 4 stent here. If you go with very long 4 stent, will be fine. You cover the whole left main LAD and the proximal stent, which is under expanded a bit, rather than using.
Yeah, I mean 4 is probably okay, but 3, 5, and 4 is the same stent, just different balloons. We can always post dilate it as much as we want, up to 5.
Because they are using, I think, what stent you are using, Khalid?
No, we're planning to use Onyx.
Onyx, okay. Because Onyx you
Onyx
can
through
expand
star
by
stent.
2 millimeter from the original size, so it shouldn't be a problem.
So we can go distal to the lesion.
Distal to the lesion.
No, that's the tip. So I want the go live.
خلي جيب تعال.
Yeah,
Okay. Oh.
go a little bit more.
This is ostial. Is it ostial?
Stop. 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 Start again. Okay.
Live. Okay, can you distal to the lesion? It's the second dot, not the distal.
I know. We are distal to the lesion.
You can ask questions if you want.
Khalid, is it 7
Okay,
French
so,
catheter or
let's
6?
start. We have 7 French. Can you start? This is the circ. This is the lesion that we treated. So here we go.
With some dissections.
See the dissection. So this is the proximal. And then we'll go to the ostial. Yeah, here okay. This is the distal left main. Okay, you can stop here. So go back and show us the ostium. Go to the left main and come back to the, yeah. Show me the LED. Okay, so this is the LED. Okay.
Can you run commentary?
This is the
Khalid?
ostial circ. You see that?
Okay.
Yeah. Can we get measurement?
Okay.
So that's 6.5. Go back a little bit. More toward the LED. Yes, 5.7. So this is the ostial circ. What do you think?
Panelist?
Because the black burden is about 50%,
Yeah.
and the area is almost 6.
I think if you do the IVUS, you've got to feel comfortable that you're interpreting it, and it does look like you've got the ostium there. And to be fair, it does not look hugely tight. So I assume you could still stent the LAD back to the left main, but then maybe reassess the circumflex after
Yeah.
that, because you may get plaque shift.
Possible, yeah.
No, I think we should keep in mind that this OM
I don't know, may I ask the
is
panelists
supplying-
regarding using the DCB and osteal circ? We don't have strong data on this actually, especially for large vessels. The DCB, the data are mainly for small vessels. When it comes to large vessels, the data are not really strong for the DCB. Any comments from the?
You want to do manual?
Okay, okay.
We let them work. So,
So عندك for stent.
any comment about
So
using
we are
DCB
going
in
to
the,
stent, you
for
can
osteal circ?
continue discussion. We'll go to stent the left main LAD, and then we'll reassess the osteal circ.
Okay, we'll let you work, Khalid and Mohammed, and just we'll have a short discussion with the panelists.
Yes, I think that's actually a very good idea to consider DCB here for the osteal circ, and see what your results are, because that's another sort of added way of doing provisional stenting.
The second question regarding the DCB, we'll use the sirolimus or paclitaxel
We have a short DCB.
DCB.
Yeah, okay.
I think for the large vessel, paclitaxel is, there is a
Give me
lot
a 3
of
DCB.
studies, relatively more than 2.75 vessels with paclitaxel rather than sirolimus, which has some advantage over sirolimus. And but I think if you want to go to DCB and in the osteal circumflex, he should prepare it well.
قرب الميكروفون.
Sorry?
ما سمعك زين.
Oh yeah, I think Khalid, is there any plan? I think you will go for a
We'll
professional.
let them work. We'll just have a discussion so that we don't distract them.
I think we'll
So if
prepare
he go
it,
with the,
so
if
how
he
about we
goes
go
with the DCB professional stenting for the,
Finish.
I think he should prepare it well. I actually from the IVITS I didn't see any
3. Give me a 3.
dissection there. There is the integrity of intimal is fine, which is almost around 270. So that can use the DCP in this situation.
We'll use it.
But he should prepare it actually before putting stent. Use DCB.
We'll prepare it.
For
We'll
circ
go with the-
and finish it, and then
go
go
with
for
the
left
cutting
main LED
balloon.
and do pot, and that's it.
Yeah.
عادل, want to comment?
I mean, I'm really worried about the osteal circ from the last IVIS image. I think it needs to be pre-dull. Either you do DCB first, or if you're not happy with the result, you should stent it. You go with upper front to stent strategy. I'm just worried now if you stent from left main into left LED, you're going to lose the whole osteal, and it will be difficult to rewire again.
And I think that's a very valid concern. If you stent across, actually, then trying to pass more kit into the circumflex becomes harder through struts. And I think if we were going to DCB the circumflex, you probably want to do that before, ideally, you stent the left main and LAD. So we should make a decision, I think, or give them some advice on specifically whether we think two stent is required here or not. But perhaps preparing the circumflex is the first step, whether you're going to use a DCB or put in a stent, I think, because I agree the ostium, just in that one frame, does look like there's disease there.
And done.
So this is a cutting balloon in the circ. Osteal circ.
Again, using cutting balloon while the wire in the other vessel.
We are doing it again
I
to
know,
prove that
I
it's
think,
okay.
yeah, I think we should prepare the stent
Scoring
very
maybe
well.
would have been safer than the cutting balloon because it's only a wire, but the cutting balloon it's blades, so the chance of cutting the wire in the other branches is high actually.
I do agree with you. Yeah, I prefer not to go through, but sometimes you face the challenges. And
Okay, no problem. We'll see.
Yeah, it's not a problem until it's a problem.
Yeah.
Very good.
See, it never happened to me.
I think the circumflex is looking much
So far, I
tidier
don't know.
now after that balloon intervention.
Okay.
I think now you can dip.
Yeah, so now we'll treat it with DCB, and then we'll go with the stent across.
So we don't have enough data regarding DCB in left main and LAD and bifurcation left main circ. But honestly speaking, if I see this, on this patient with this after cutting balloon, calcium modification, use rotablator. Perhaps in the future we can use DCP and lift the area with no metals there. Because it really looks, what they have done, the team there is really look grateful, and I think everybody who look at this will not feel that there was a left main stenosis or a circ. The visuals look patent well.
So what you're saying is that if you had just used DCB, you would be more assured of just having a provisional strategy.
Maybe in the future, yeah.
Down and down.
And actually, there are now drug-eluting balloons, but the data are not yet out. It's a drug-eluting balloon with a microreservoir. And it's not a DCB where really the medication is already just displayed to the endothelium. It's eluted slowly to the endothelium.
If you allow me, I'm just curious, what's the LVDB for this patient at the beginning?
It was 15.
15.
1.5, yeah.
15. 1.5.
Pressure's coming down. Pressure's coming down.
30 seconds.
Because the strategy was if the EDP is high, they just will go up front with LV support, actually. Silent?
DCB.
Size of the DCB?
315, he said, no?
3.
Yeah, DCB 30 seconds and then pressure starts dropping. So
Pressure is dropping, so we stopped after 30 seconds.
No, the size of the DCB.
Which is sufficient, I think.
Size.
Size went 3.0.
3, okay.
We're just trying to be gentle. It's a 3.5 bezel.
Okay. So what's your next step, Khalid?
next step will stent.
Yeah, picture.
Okay.
Gentle.
You know, after putting the stent, regarding the depth, given the history of stent thrombosis, will you change it from Plavix to ticagrelor instead of Plavix? We don't know.
Yes.
For sure.
The
Sure,
patient
yes.
for the past 7 years, he was very compliant to treatment, so there's no issue with compliance. But in view of previous thrombosis, for sure, here we will discharge him on ticagrelor.
Okay. You want to say a comment? Or?
Yes, I mean, if you haven't already, yes, I would definitely go to ticagrelor,
What is it?
possibly
Oh,
prasugrel,
no,
but not clopidogrel.
Okay. So we'll go from mid shaft to where the twitches.
The problem, somebody with stent thrombosis whom you don't have a reason when you clear the patient, you just do the aspiration, you do the IVUS, and you see there is no reason for this stent to thrombose. Anybody will do platelet aggregatometry testing or not?
Well, I usually switch him to a potent antiplatelet. I don't bother doing any testing. If it's not stent failure issue.
Yeah. So,
And either it has to be patient failure or medication failure.
but patient is compliant. You see the stent and the LID is well expanded, maybe just undersized, yes, well opposed. But and there's no reason for this patient to get a stent thrombosis. So, anybody is doing the platelet aggregometry testing? Have you done it before for any case for stent thrombosis?
Get your guy down.
I remember last time we have done it is before Corona pandemic. And after that, we haven't done any test for
Can we do
platelets
stent
or
boost?
for platelets.
Can we do stent boost?
No.
Okay.
I think
We don't
you
do
can
it.
come back.
We stopped long ago.
We have to give a distance.
No, I think we in the UK anyway recognise that there is a significant proportion of non-responders to clopidogrel,
Yeah.
particularly people from the South Asian community. But actually, we don't see stent thrombosis to anywhere near that level, so we don't test for.
Test.
Yes, we don't do any routine testing either, and when there's a situation like this, I don't even, no matter if the test says that they're a responder, I would still use, a higher potency antiplatelet like ticagrelor or prasugrel.
Are you trying to nail the ostium now?
Actually, we are trying to see where is the stent to avoid too much overlap. So we are well inside the stent, maybe 3 millimeter inside the stent.
But the question is, are you going
And
to
we
the
are
ostium
covering
direct
not
or to the
ostium
mid shaft?
proper, but close to the ostium. So here, you see?
Okay, we'll go up here.
I think from memory of the IVUS, the ostium of the left main was not diseased, so having to
Yeah,
nail the
so-
ostium isn't important, but you probably don't want to leave a gap between the old stent
Yeah.
and the new one ideally.
So you will stop
Yeah,
at the
so we
mid shaft?
covered the overlap area, and now we are going with the stent.
16.
He is tolerating. Okay.
Go up here.
So at what pressure?
I'm doing 16. 16 because this is only 3.5.
Okay.
And down.
Then you'll use 5.0 balloon?
We'll use 5.0 for bot.
Okay.
So give us a
Anybody have
4
used
first.
ostial flash balloon?
4.
Anyone?
4 15.
Just the bot to
Panelist?
see the cell.
Ostial flash balloon? No?
The picture.
We, you know, it works when it works, but sometimes we've had some issues with the osteoflash. So, you know, I think if you're experienced, but you have to be very careful that you know that it's properly placed and that you don't actually cause osteal dissection.
Fast.
Okay. Now the ostium of the circ looks pinched.
It's a pinch a little bit, so we'll do kissing. But first we'll do bot. We'll boost the overlap area,
Yeah, okay.
and then we'll do bot. And
So
then
you're
we
using-
recross into the.
What length of balloon you are using for the part?
4 20 NC.
For the bot, we'll use a shorter balloon. That's the 5.0. But this is we are going to the LED now. We want to optimize the overlap area.
Okay.
Go up here.
So this is 4.0
Go to 16.
at 16.
And down.
Still a waste.
Again here.
I think this is an excellent example. For those of you who were in this hall for the previous session, we had Ziad Ali talking about the importance of intravascular imaging and the clear benefits. And I think this is a really lovely example of how actually doing the IVUS doesn't take very long.
Okay.
It does tell you exactly what kind of balloons and stents you're likely to need. You can optimize everything and then have another look to see if you've got the right result.
Yes. Yeah, very good.
Sure. 8.
So you'll use 5x8?
Yeah, 5.8 NC balloon for the bot,
Okay.
and then we recross.
And then do kissing.
And then we do kissing and repeat bot maybe and imaging.
This is the problem with the ostial circ. Usually it's problematic, and recoil is very high, restenosis is very high.
But the area of ostial circumflex after they did IVUS, it's good. It's around 6,
Yeah.
6 plus.
Yeah,
And
but
then with the post-cutting balloon and DCB, it looks really good.
Yeah.
So this, the one we see here, it's like a deceiving because it's related more to the blood flow and carina shift rather than a true lesion there. So I guess if I were him, I would leave him alone. That
Okay.
leave it with time, with everything. With pot, we'll see better result really, or we can take
Okay.
another caudal view.
I want to do stent boost.
Okay.
This is good. This is good.
Okay, go up.
But my part show stent boost.
So, as the former speakers, panelists said,
Ready for send book?
proceed with imaging after this before addressing the circumflex.
I mean, that's a good idea.
Yeah.
So let us do the bot and then take a picture, and then
what pressure you are going up to? Khalid, what pressure you are going with the 5.0?
16.
Okay.
So 5.016.
Okay.
And then we can take a picture and then maybe do imaging.
Let us recross first.
Maybe we don't have to do anything. So let's take a picture.
Okay.
Nitro and picture.
Can we take a picture now?
Yes. Yeah, we'll give nitro, and then we'll take a
200
quick
of
picture.
nitro.
Your guide is good. Yeah. What do you think?
No, we need.
Smash the panelist, will you stop at this stage or you will proceed more?
Spider. That's good, Spider.
Yeah, can you take another caudal view?
Maybe another view.
We are going spider.
Another view just to look at it.
It's nicely T3
Yeah,
flow.
we'll show you the
and,
spider view.
Okay.
Yeah,
Yeah,
looks
I
fine.
think it looks fine.
Looks good.
Really looks fine.
I mean,
Anybody will do final
sometimes,
kissing?
sometimes if you are in doubt,
So
you can
let's
take a
IVUS,
fart, and you will be
from
surprised
the
most of the time
LED.
this will be negative.
There are times where it does look pinched, but actually you look again sometimes for a staged procedure and actually the circumflex does look fine.
Okay.
And I think you made a great point. Sometimes this is a little bit of plaque shift. You've changed the carina. I don't think you have to intervene here, but again, maybe an IVUS here would be really helpful to reassure you.
About that. So Khalid and
So
Mohammed, you will do Khalid?
So
We'll
we'll
do
do
IVUS
we'll
for
do first
the
IVUS
for the osteal
If
circ,
you don't do kissing,
to
you will not
evaluate
be
the
able-
osteal circ.
I mean, now we are going to the LED, evaluating the stent in the LED.
Okay.
Of course, the IVUS
start
may
with
not
that.
cross easily
Yeah.
into the osteal circ
Yeah.
because of the
The
angle
IVUS
now.
probably will not cross unless we do kissing, and if we don't want to distort the stent and do unnecessary kissing, maybe we just leave it alone.
Okay.
So we are across distance. Huh?
Yes. So can you reset?
Yeah, 1 second.
Okay. Start.
Okay. So we are starting from, this is the overlapped area. And you see it's well opposed, can get a little bit bigger.
Okay.
But we'll see the area here. And this is the left main.
Okay.
I think some part of the IVUS now in the proximal LED before you arriving the osteal area, there is some pinch there at the 11 o'clock. This is maybe due to calcium,
Yeah.
but the circular shape of the stent is great in the now it's become so you see that the stent changes its shape from rounded to oval.
Yeah.
That's most likely because
So we have an area of 10.
of calcium rather than
And,
because of, and this area honestly need dilatation. It's optimization. It's not opposition. It's the stent is well opposed.
Okay.
But, and there is no term in actually in intervention. You know what? It's to keep the stent round shape rather than oval shape. What's that called? It's part of. I think it should be part of intervention ballooning is to maintain the integrity of rounded shape stent rather than like you go round and then become oval, then become round again. We shouldn't create a term for that in intervention. And because I think that area would change its shape, some luminal flow limitation, you know, so better to go for ballooning.
Again?
I don't know, it's just raising some innovation area.
Anybody will
It's
use
deep
ballooning
calcium.
again?
I don't think
Lift
further
me looks-
balloon
The
is
results are very
Very well.
satisfying.
Yes.
What is that?
I'm satisfied.
To balloon.
Are anybody who's
Distal.
I suppose the key here is what is the MSA. That's what we're really after. And if it is oval, often after orbital, for example, we see that the vessel is a bit more oval shaped. But
Yeah.
I think as long as you're getting an adequate area in the left main, I don't know how much more you can then do beyond pressing with a high pressure balloon.
Yeah, I would agree. I mean, the anatomy changes there, and if you continue to press it, then, perfect is the enemy of good. So I think this is a good result so far. Thank you.
Okay.
And you can see in the IVUS that the ostial circ is good. It's not bad. Like you see the branch side, the branch is coming out, which is good.
Yeah. Khalid?
Yeah, I think we are satisfied. I don't know.
We can take our final pictures.
Panelists, what do they think? But from our side, we are actually very happy with the result.
Okay.
And we are actually thinking of just stopping at this stage. I don't know, what do you think?
I agree with you.
This looks great. I mean, if you look at the graph of expected events from left main PCI, an MSA of more than 13, I think, gives you an exceptionally low recurrence rate, and predominantly your MSA is largely above 12 throughout most of this vessel. There's a little bit under. It looks like a very good result in the left main.
We can do a 4-5.
Comment,
Left main LAD.
Mohammed? One from the audience.
They are asking you from me.
Okay. No.
I think we have achieved what our target. Okay, there's good flow in the circ. Okay, there's
mic is
good
not
expansion of the stent, good opposition. There's some areas of irregularities, but I think if you aim for perfect result, you might get the reverse.
I think we are satisfied all, Mohammed, with the results. Very good job. Just one comment from Dr. Mohammed Al-Mtairi.
Yeah, great job. I'm just wondering if you're going to do anything for all the LED stents, because you did the overlap there and you went with a high pressure balloon. So would you consider doing DCB there, just to finish the job?
Mohammed, do you hear there's a question from the audience.
I hear his question. He's asking
yeah.
about DCB in the LED stent.
Yeah.
Yeah, I mean, it's probably not a great idea. What do you think?
Yeah, we can do that.
Okay.
So, yeah, I think we like it.
I'd have left.
So maybe we'll go and...
This is Assalamu alaikum. This is Shamim from the UK. I probably would have left it, actually. If you think about what your goals were at the beginning of this procedure, I would say you've saved this patient from bypass surgery. He had a severe distal left main lesion, and actually you've got a very good result. And I think when you first did your IVUS of the LAD, it was a little bit under-expanded, but actually it looks very good.
Yes, I agree. And I think, I know we're running out of time, but the big question long-term is how you follow this patient. Are you going to think about imaging? Are you going to think about clinical? Are you going to think about angiography or stress, or just follow the patient clinically?
Very good. Comments from...
Excellent result, actually. The only thing I would do here further is just opening the strut towards the circ. Just because, like data shows that new intimal growth of the struts that coming across the lesion can lead to restenosis in the future. Especially this patient, he's young, he's active. I think I would open the strut and finalize with pot, and then finish the procedure.
Any comment? Final comment?
No, nothing. I think if you decided to leave the circ alone, with that appearance of binging, and it's an important vessel, I might actually consider FFR just to be on the safe side.
Okay.
If it's reassuring, I'll just leave it as is.
Okay. Angiographically looks okay. There is a question from the panelist, Khalid Mohammed. Doing FFR for the ostial circ. To evaluate.
FFR to ostial circ.
And we have a surgeon here who's Dr.
Ahmed Al-Arifi, cardiac surgeon. I think excellent.
Ostial lesion, even if they look,
we take a picture here.
Can you lower?
We took.
Okay.
Shows there is
So focal ostial lesions, even if they look very tight,
Khalid Mohammed,
probably the FFR will be negative.
Mohammed, Khalid, we have a comment or question from a cardiac surgeon here in the audience. Dr. Arifi.
Yes, please.
Thank you. It shows that excellent operator have shown experience. My question here from the beginning, there was apprehension for the complexity of the lesions. and there was a decision dilemma. Just because we can doesn't mean we should.
Yeah.
Now have seen how this procedure went and the outcome. What would be your decision for the next similar patient? And this question to the panelists and the operator.
So I'll pass it to the panelists.
I will send them to you, don't worry. Well, we'll do the same. It's been done well, really. It's very nice procedures.
Okay.
I think we have
And you can see how easy to recross into the circ with a new wire.
There's an osteocirc lesion. We shouldn't deny that.
Yeah.
There is a question regarding long-term durability and stent stenosis and thrombosis.
Yeah.
So, morally, will I leave this alone, or should I think about for the next similar patient? Maybe we should do different decision, and this is the whole idea of our practice. We need to change our decision and learn from what we do.
Thank you very much. Anybody will have a comment on the comment of the...
I mean, you're right. You know, we need to reflect always on what we do, but I think also that there are more considerations than just the anatomy here. When you looked at the first angiogram, I really thought this would be a two-stent strategy. This was a relatively complex-looking bifurcation, but actually you also want to bear in mind the previous stent thrombosis, where we don't really know exactly why that happened, how far away was it, and when there's some uncertainty, I think limiting stents here is probably not a bad thing. And also, I think in this scenario, you don't necessarily have to do everything now. We've got a really good result in a patient who's had two vessel rotablation, multiple IVUS runs. Actually, we can see them in clinic. If there are concerns, we could always bring them back, have another look, pressure wire the circ, and then decide thereafter. But I think that's the nice thing about planning what you're going to do, but then reflecting on how you could do it later. I think we've got a couple of options here.
Yeah, I think the patient is willing, and you know, if he needs to come back again at another time, then so be it.
Okay, I think we have to... Mohammed, Khalid, do you want to say final comment before we conclude? Because it's already 10 o'clock, 11.
Yeah, I think... so for this patient, we actually initially offered him CABG, and we still that may be the best option for durability. However, we have to take into account also patient preference, and also we have to ask ourselves whether we can achieve a reasonable result or not. So that what we thought is that we can achieve a reasonable result in this left male. Looking at the angio myself also, I thought that this is a two-stent strategy. Actually, I was going into the case thinking that I would really need two stents. We're thinking about decay crush. But then with the imaging, I started changing my mind. And also after we got a reasonable result with the DCB in the circ, we didn't have to stent the circ, then that was even more compelling to just go for just minimize stenting. And this is how we end up with just one stent from left main to LAD with minimal overlap with the other stent. As you can see, the osteocirc is wide open, even by angiography, and circ lesion was treated. So we're actually very satisfied with this result. We'll ask the patient to come to the clinic, and we'll evaluate if he's having any symptoms.
Okay.
At that time, maybe we can decide if we need to have a relook and to reassess the osteocirc again.
Okay.
But with this result, I'm actually very happy. And for the kissing, it depends. For me, if there is no significant pinching, I can see, like in this case, I will just leave it. This is usually my practice, and you know, I know there are conflicting data in this arena, but you know, all those are small studies. If we have a large studies that showing clear superiority of kissing after like routine kissing after provisional stenting, then that's maybe I will change my mind at that time.
Very good, very good. Thank you very much, Khalid and Mohammed. Excellent work, excellent results. Thank you very much.